Greetings! Our patient for this case is a 34-year-old HIV seropositive woman who was presented with a fever, productive cough, diarrhea, headache, dizziness, anorexia, nausea, sore throat, and dysphagia or swallowing difficulties. And she also noted a 10-pound weight loss over the previous 2 months. She did not receive any treatment for her HIV infection or prophylaxis for opportunistic infections. And on physical examination, she was malnourished and in acute distress due to diarrhea. Although her vital signs are normal, her chest examinations were abnormal, with basilar crackles or the bubbling sound, which distributed up to the mid-lung field. And her partial oxygen was only 77 mmHg while breathing the room air. And her chest radiograph showed diffuse interstitial infiltrates and a small pleural effusion in the right lung. Her white blood cell count was kinda low with 3,700 per UL with an absolute lymphocyte count of 600. Her HIV viral load was way up high because it has greater than 750,000 copies per ml. And upon bronchoscopy examination, the organism detected the bronchoalveolar lavage or your BAL specimens from both lungs, which is seen in the presentation. And that's the case that we are about to unravel.
Pulmonary infections can be caused by a variety of organisms, hence ensuring appropriate examination, medical history checking, and careful identification of microscopic details will help diagnose the causative agent of the disease that will aid in the treatment of the patient. Supported by figure 13.1, the patient is suffering from a pulmonary infection caused by the organism Pneumocystis jirovecii, formerly called the Pneumocystis carinii. The microscopic details shows cyst-like structures approximately 5 micrometer in diameter, which is a distinguishing characteristic of the organism Pneumocystis jirovecii. Pneumonia remains a primary cause of pneumonia in HIV-infected people, despite the fact that the frequency of this illness is high. Infected people has dropped considerably in the developed world since the advent of highly active antiretroviral treatment or the HAART. Pneumocystis jirovecii is frequently seen as an AIDS-presenting illness in a person that is unaware if he or she has HIV. It can also be seen in individuals who are non-compliant about the ART and those who haven't received treatment at all. Other possible organisms causing the disease may include bacteria such as E. coli, Streptococcus pneumoniae, Legionella pneumophila, Mycobacterium tuberculosis, and Haemophilus influenzae. Viruses such as influenza A virus and respiratory syncytial virus in HIV-infected children, and fungi including Histoplasma capsulatum, Coccidioides immitis, Blastomyces dermatitidis, and Cryptococcus neoformans. The patient's white blood cell count of 3,700 microliter and absolute lymphocyte count of 600 already gives us an idea that her CD4 cell count is below normal. The nature of HIV and its specificity to infect CD4 T helper cells also supplements the idea of a lowered CD4 cell count. Next, it's expected that the patient's CD4 cell count is less than 200 per microliter. For reference, 500 to 1,300 microliter is the normal value. It's considered the hallmark infection of HIV. Pneumocystis jirovecii is considered an opportunist fungus and is capable of a successful infection to those with weakened immune system.
Pneumocystis jirovecii can be treated in two ways in patients who are infected with HIV. The first approach is with the use of prophylactic antimicrobial drugs when the CD4 count becomes less than 200 cells per microliter. Trimethoprim sulfamethoxazole is the primary drug of choice, but alternatives are available if the patient cannot tolerate the drugs such as dapsone and aerosolized pentamidine. The second approach is by treating the HIV infection in order to bolster the immune system with the use of highly active antiretroviral therapy, which has been shown to be effective both in delaying immune system damage by greatly slowing the decline in CD4 cell counts and in reconstituting the immune system. The least invasive and least expensive diagnostic approach is to examine an induced sputum sample for the presence of typical pneumocystis jirovecii cysts and trophocytes. BAL or bronchoalveolar lavage, as was used in this case, has a higher diagnostic yield than other types of bronchoscopic examinations and induced sputum. This technique has a diagnostic yield of 90 to 95% for pneumocystis jirovecii detection in patients with AIDS who have not been treated or given prophylaxis with antimicrobial agents. In selected patients with a negative BAL examination, lung tissue can be obtained either by video-assisted thoracic surgery or by open lung biopsies. Pathologic examination of this tissue is considered definitive for detection of pneumocystis jirovecii. In non-HIV infected patients, examination of induced sputum is not typically performed. As a result, bronchoscopy with BAL would be the initial diagnostic step for detecting this organism in this patient population, followed by video-assisted thoracic surgery or open lung biopsy if deemed necessary.
It was thought that these infections were caused by the reactivation of dormant organism because serologic showed a high incidence of herovesi, seropositivity early during your childhood days or one's childhood days. And researches regarding molecular epidemiology actually identified the cause of the causative agent, including the causative agent's DNA as detected by PCR in respiratory tract samples exposed to patients with pneumocystitis infections. So these investigations revealed that the P. jirovecii is typically transmitted from a direct contact, like from person to person. And based on the understanding of the case study, infections will arise from either the reactivation of dormant organisms or even the acquisition of sick people or those who are immunocompromised. And the respiratory infection caused by this organism does not only occur in just a healthy person, but instead they get to colonize it. And the sad thing about this is that apart from the risk groups, patients can be a carrier of this disease or the carrier of the causative agent. And in these cases, the immunity of the patient, particularly in the cell-mediated immunity, they're usually disrupted, which really affects the protective mechanism of the person. And in this case, the way HIV impairs your cell-mediated immunity would actually reduce your CD4 or your positive T helper cells, which makes the causative agent pneumonia a frequent infection in patient population. And in addition to that, there are also unusual clusters of your P. jirovecii infections, especially on homosexual men, especially in Southern California, especially during the discovery of AIDS. And when your CD4 T helper cells are usually lower than 200 UL especially for adults, there is a greater likelihood that the patient would have pneumonia because of this causative agent. And usually the therapy for this is your HAART or HAART, okay, which significantly reduce the prevalence of having this kind of pneumonia or any HIV infected related diseases that causes the P. jirovecii. And it actually continues to be the most common serious opportunistic infection in patient population because, in researches, individuals with hematologic malignancies, especially when you do bone marrow transplants, are more frequently of having your pneumonia due to this causative agent. And I think that's so far how this causative agent would actually acquire pneumocystic infections and even its epidemiology.
For question number 6, this is because the organism binds to type 1 pneumocytes in the alveoli, which causes diffuse injury to the alveoli with leakage of exudate into the airspace. The presence of this exudate, which is pink on the hematoxylin and eosin sections, which is seen in figure 13.2, prevents proper oxygen exchange between the alveoli and the bloodstream. Thus, this results in hypoxemia, as measured by a low PO2. For question number 7, the cause of this patient's pulmonary signs and symptoms is the pneumocystis jirovecii, but is an unlikely cause of dysphagia and sore throat. On physical examination, this patient had white plaque-like lesions in her throat. A KOH wet mat of scrapings of one of these lesions was examined microscopically and revealed the organism seen in figure 13.3. In these tissue sections, note the yeast forms and pseudohyphae. This is consistent with the presence of Candida species. Candida albicans is the leading cause of oral thrush, which is a common opportunistic infection in AIDS patients. These patients' dysphagia, sore throat, white plaque-like lesions, and laboratory findings are consistent with oral thrush. She was then treated with oral fluconazole, triazole antifungal agent, and her symptoms were resolved. Similarly to pneumocystis cerevisiae pneumonia, thrush is generally seen only in patients with CD4 counts that are over 200 UL.